when we understand some of the biology of ADHD, it makes it make sense. And it changes how we look at it and what we can do with it. All right, without further ado. So I'll be talking about the characteristics, correct diagnosis, because there's differences in characteristics and diagnosis, and what to rule out, and then treatments that can be beneficial. So this first portion, I'm just going to go through the DSM. So we're going to go through the DSM. I'll talk about the criteria. Then I'll also kind of explain like what that may look like. So some major features, and I'm gonna move this so I can see this better. So major features and characteristics. So some features of ADHD is impaired response inhibition. So there's problems with impulse control. It's difficulty with delayed gratification. It is a regulation disorder. Now we say attention deficit, but it's not just difficulties with regulating attention. It's also difficulties regulating emotions, regulating our behaviors. So excessive talk uh, on things that, irrelevant activities, um, as well as, poor sustained attention. So you'll see that it's not just, oh, I can't pay attention. There's lots of things that can do that, but it's more than just executive dysfunction. The reason why there's executive dysfunction makes it entirely different than a head injury. So some other features and characteristics, particularly with the impulsive behaviors, there's working memory problems. So with someone with ADHD, if you give them a set of directions, okay, I need you to go do this. I need you to go to the cupboard. I need you to grab the specific thing. I need you to take it over there. And then I need you to do this. I also need you to do this. Like, that is unlikely that they will be able to remember that. A common thing that we see, like with couples, hey, honey, I need you to go to the store and pick this up. They go to the store, they get something else, but they don't get that item. Or they're given a list and they can only remember part of the list. Also, there's delayed development of internal language. This one is particularly interesting because thinking through things, and not just thinking, but thinking with like an inner voice, can be helpful with executive functioning. So you'll see some people maybe sometimes talking to themselves out loud, oh, I got this to do, or I do this and I do this. And there's actually a study I read that showed that verbalizing one's inner thoughts can help with ADHD and help with executive functioning. There's difficulties with regulating our thoughts, our attention, motivations, emotions. Um, for someone who has ADHD, there's a lot that is outside of their control. They're in a boat, but they're not really able to steer the boat as well as someone else could. Um, so they're, and I'll get into why that is. With ADHD, there's diminished problem-solving ability, flexibility, pursuing long-term goals. There's greater variability with task performance. So a lot more mistakes, for example. So that's kind of what it looks like. You'll be talking to someone and they'll kind of like, either they will start to daydream and they'll look elsewhere, or maybe they're trying to pay attention. So they grab something and they're doing this, and it seems like they're not paying attention, but actually the stimuli in some ways actually helping pay attention. But this is tricky because if they're doing something and then you come up and talk to them, it's actually unlikely that they will pay attention. But if they're talking to you and then they're fidgeting, in situations like that, it may actually help them. So it's a little bit different. Typically, we see someone doing that and we think they're not paying attention. Well, that sort of stimming is providing something for their brain to do, and without that, internally, their thoughts might go elsewhere. So their thoughts might go to daydreaming or their attention will leave. But if they're active, it can help. All right. So I really want to talk about next the diagnosis, what it is, and then talk about what needs to be ruled out. So I see like on TikTok, there's debates whether, self-diagnosis is valid for certain things. But when it comes to ADHD, symptoms does not mean diagnosis. You can have all the symptoms, but also not have ADHD. That's because ADHD is entirely like it is a developmental disorder. Um, it is something that is passed on through our genes. It is genetic. It's something that is lifelong. So we might have symptoms, but it might be from sleep apnea or mental fog from COVID. So there's a lot of things that can come up that we'll need to kind of sort through. But let's go through this. So with the diagnostic criteria, there's a persistent pattern of inattention. Sorry, I need to. And or hyperactivity, impulsivity that interferes with functioning or development. So there's inattention, there's six or more, so inattentive type, there's six or more of the following symptoms that need to be there for 6 months. But you'll notice underneath that it's not solely a manifestation of oppositional behavior or defiance. And for adolescents or adults, you can have 5 symptoms. So the reason why it says oppositional defiance there, or oppositional behavior and defiance, is because they look very similar in kids. I often refer to oppositional defiance as like ADHD's best friends. They like to hang out, so to speak. But they are different. So diagnostic criteria for the inattentive type often fails to give close attention to details or makes careless mistakes in schoolwork, work, activities, misses details, so work is inaccurate. So this could be a kid that turns in paperwork, but their name's not on it. Or there's a couple things that are missing, or it's mostly done, but not all the way done. Often has difficulty sustaining attention in tasks or play activities. So sticking with one thing for a long period of time can be difficult. Often does not seem to listen when spoken to directly. This often will cause issues with relationships where someone is in their own world and they're not in the present. They're not absorbing that information. Often does not follow through on instructions and fails to finish schoolwork, chores, duties. Oftentimes, that can not just be a motivational piece, but a working memory part also. Often has difficulty organizing tasks and activities, difficulty managing sequential tasks, difficulty keeping materials and belongings in order, messy, disorganized, poor time management, things like that. Often avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort. So yeah, things that this could be a variety of things, but this often leads to procrastination. So someone has a non-preferred task, they will save that to the end. If it's school, the thing that they really don't want to do, they will leave until the last minute. And then sometimes the night before, there's a surge of adrenaline, and that sort of works as a stimulant, and they're able to complete that task and still somehow do well. Often loses things necessary for tasks or activities, pencils, pens, phone, wallet, glasses. What helps in these situations and what some people start doing just naturally is coming up with some sort of system that works for them because they misplace their phone and their wallet at their home. Then there's a designated spot and they get into the habit of just putting it in that spot, because if that was not the case, they would misplace it. So people tend to adapt. Is often easily distracted by extraneous stimuli. This could be someone is trying to work on a presentation and, oh, there's this thing on the wall. I've never noticed that before. Even something as simple as this thing on the wall is pulling their attention away. So for the rest of us, it might be in the background, but for them, there's no such thing as a background. So it makes it very difficult. Is often forgetful in daily activities. So things like brushing teeth, eating. These are things for a lot of people, just normal and natural. But sometimes with ADHD, no, it's not necessarily habitual. It takes mental effort to do that. It takes putting systems in place. It takes, they can't necessarily rely on themselves to remember that. So this is the inattentive type. Are there any questions about the inattentive type before I move on? Okay. The hyperactivity and impulsivity also needs to be here for at least 6 months. And from childhood, prior, oh, we do have a question. Okay.
Took me a minute to find the mic. I'm starting to get these problems in that. So can you get ADHD later in life? I was also in a bus accident maybe 15 years ago. I don't know if that's the cause of it or I'm getting ADHD later in my life, but I've been diagnosed with it later
So,
in life.
yeah, that's something that I will come to. So typically
Okay,
speaking,
thank you.
typically no. You can have all the symptoms, but what makes it different is that it is a developmental disorder. So for example, it's thought with ADHD that there are 80% more dopamine receptors. So someone is working on a task and dopamine that's associated with attention, motivation is vacuumed up. So they're starting a task and then it's gone. And so continuing that task is now difficult, uncomfortable, incredibly boring. But that's why something on the wall that's now providing dopamine is more interesting. Um, that is one of the things that makes it different and why you can have the symptoms, um, but not necessarily have it be like an adult onset. Now, there's a few reasons of why this could happen. It could be that symptoms were present as a child and they were not as intense until, let's say, someone is an adult and now they're having to do things for themselves and they don't have that structure, and now things are incredibly difficult because they're having to do all of that themselves. And so it's more noticeable. Or the symptoms were there as a child and they just were not diagnosed. Or it could be that something that's mimicking ADHD and has a lot of the symptoms, but treatment is different. So, or medication wise, but some of the therapy treatment can still be helpful. So if there's a head injury and there's executive dysfunction from the head injury, some of the same strategies, at least in therapy, that would help for ADHD also might help for therapy. For example, if I learned that I cannot trust my memory, and accept, I can't trust my memory, therefore I'm going to write everything down. If I ever tell someone I'm going to do something, it's written down. That's adapting. That's adapting to a head injury or a poor working memory or ADHD symptoms. Um, but in the case of ADHD, I would need to have this um, on me at all times, like maybe even a chain to my belt, because with ADHD, there tends to be losing things. So as far as adult onset, I'll talk a little bit more about that later, but typically there's reasons why it tends to appear. It can be mimics. It can be that it was there and just not noticed, or the symptoms were there and they just were not diagnosed. So,
Preston, there's one other question in the chat. Mackenzie's asking, do symptoms show differently in adult women?
yeah, I mean, not just adult women, but even boys to girls or even boys to adults. Um, so, for example, with let's take kids first. Let's say um, a boy. A boy, when you think about ADHD, you think about climbing on things and running around. If it's a girl, it's more chatty, someone that just wants to talk, but not necessarily running about and climbing on things. And as adults, um, a lot of the hyperactivity becomes internalized. So it looks a lot like anxiety. So sitting still is uncomfortable. Sitting still, like you want to be moving, and when you're moving, it's even like shaking your foot or something, it's more comfortable. Um, and also, sometimes also with your thoughts. If you're sitting and you're not thinking, and oh, that might be a little bit uncomfortable, you'd rather be thinking about something and having your mind go. Um, but as far as ADHD in adult women versus ADHD in adult men, um, I'm not familiar enough with the research there to say what all of the differences are, but I will say there is research showing that there are differences. So I hope that helps. All right, moving on to the hyperactivity, often fidgeting or tapping with hand, feet, squirming in seat, often leaves a seat in situations where remaining seated is expected. So as a kid in a classroom, might be getting up and going and talking. As an adult, this may be okay. Say a family is trying to sit down and watch a movie, and then someone sits down. You know what? I gotta get some popcorn. They get up and get popcorn, come back down. You know what? I gotta get us drinks. They get up, get drinks. They get down. You know what? I gotta get this one more thing. They get up, get something else. They grab their phone. They sit down. Not only are they going and getting things, but the things they're getting are give them dopamine so they can sit there longer. So that's something that you'll see just anecdotally from people who have ADHD. Um, so often, this one right here, often running about or climbing in situations, that's more just boys. With adolescents, adults, it's feeling restless. Um, Often unable to play or engage in leisure activities. It's uncomfortable. It can be uncomfortable to sit down and not do something. Um, Often on the go, acting as if they're driven by a motor. Um, just having this desire just to do and just not stop. That's part of ADHD, or can be. And then often talks excessively. There's also blurting out answers, before a question has been completed. I love to ask this question slowly with people when asking them, you know, in the initial intake. And if it seems like there's ADHD, I go down this line of questions and I ask, do you often blurt out an answer? And then I find it just funny when people just blurt out and say yes or interrupt them. Difficulty waiting in line or waiting their turn, interrupting and intruding on others. That's also part of the hyperactive and impulsive type of ADHD. So these symptoms need to be present prior to age 12 in order to have a diagnosis. So that is in the DSM. So that's why adult onset is not something that would line up with the DSM, and also doesn't necessarily line up with our understanding of it being genetic and how it presents in the brain. Several inattentive or hyperactive symptoms need to be present in more than one setting. So if it is just one setting, if it's just at home, or if it's just at school, it's likely that it's something else, it has more to do with that sort of situation. But if it's coming up at work, at school, at home, with friends, that's ADHD, because this is a problem with the brain, not a problem with the situation. There needs to be clear evidence that this interferes with or reduces quality of social, academic, occupational functioning. And symptoms do not occur exclusively with the course of schizophrenia or another psychotic disorder, and are not better explained by something else like anxiety, dissociative disorder, personality. So there's the predominantly inattentive type, predominantly hyperactive type, and then when they meet both criteria, there's the combined type. Sometimes as people grow, there's a remission of symptoms or even a partial remission. So there's a difference between, you know, how many kids have ADHD and then how many adults meet criteria. The reason for this is kind of interesting. They've shown in MRIs when the parietal lobe lights up. With someone with ADHD, the frontal lobe doesn't. With someone without ADHD, the parietal lobe lights up, the frontal lobe does. In people who have symptom remission, that's actually what happens, is now the frontal lobe is activating with the parietal lobe. So it's not that they don't have ADHD. It's not like suddenly, you know, the more dopamine receptors are gone. There's still going to be structural aspects of ADHD in the brain that are still there, but the brain has found a way to compensate and work better. So it is true that some people can grow out of it and no longer meet criteria. They still might have 4 symptoms, and then the other symptoms are not as problematic. So it's not like they suddenly have a different brain. It's just that those things are not as problematic as it used to be, if that makes sense. So all the biological aspects of the brain are still there. So some things that we will need to rule out when meeting with a patient, we want to rule out a lot because there's a lot that can affect our functioning. So sleep apnea, that's going to affect executive functioning. Response time, seasonal affective disorder, head injury. When there's head injuries, yeah, that causes a lot of symptoms that are ADHD symptoms, but the cause is different. The cause is from the head injury. PTSD, that's interesting because with PTSD, it has an effect on the anterior cingulates where it gets smaller. And I believe over time with ADHD, that also happens, as well as other parts of the brain will kind of change over time with ADHD. Then there's also post-COVID-19 mental fog. So this is just some, and there's more. There's mood disorders, anxiety disorders, dissociative disorders, personality disorders, substance disorders. So with so much to rule out, what could we possibly do to make sure it is ADHD and not something else? Because this seems like a whole lot of work going through and making sure that it's not something else. Well, let's say if it's a substance use disorder, there's going to be an onset. If it's a dissociative disorder or PTSD, there will be an onset. So one of the biggest rule out questions is, was there an onset of these symptoms, or have these things been problematic your entire life? If it's always been there, that's a huge clue that it's developmental. That's a huge clue that it's likely ADHD instead of something else. If there's PTSD and ADHD and you don't know, and you find out, okay, these symptoms happened right after the PTSD, it has more to do with that. And this is important because medication treatment is going to differ. So this is a big rule out question that will be helpful in accurately diagnosing ADHD. We talked about this a moment ago. What about adult onset ADHD? There are some studies on adult onset ADHD, but there's a systemic review that showed that there is insufficient evidence for the claim. These symptoms seem to exist, but their source could be adult emergent symptoms that were previously surpassed due to lower environmental demands or supportive facilitators. 2, mimics that were not properly assessed. Or 3, childhood onset symptoms that were not detected earlier due to failure to come to clinical attention. So the studies that are out there right now about adult onset ADHD have not really shown that it's not these other things. They haven't shown that it's not all these rule outs. They haven't. So there's going to be a lot to prove to show that ADHD has an adult onset. And if that ever comes about, it will entirely reshape how we view ADHD. For right now, it is viewed as a developmental disorder that is from birth onward. So I talked about this a moment ago. What about symptoms in remission? Then I talked about the MRI and the parietal lobe and the frontal lobe. With ADHD, there's no observed synchronicity, but with people who have remission, there is. Or people who have or don't have ADHD, there is. So this is likely why there's a greater percentage of kids who are diagnosed with ADHD than adults. So 7.2% of children have ADHD, whereas only 2.5% of adults are meeting criteria. So this would be considered ADHD in remission. So those symptoms are not as problematic as they once were. So some general info. This is hereditary. It's 74% hereditability. So if you were meeting with a family and mom and dad have ADHD, good chance their kids are going to have ADHD. Or even if the kid has ADHD, good chance one of the parents have ADHD, or even ADHD in remission. Life expectancy for ADHD is less, 20 years less. In persistent cases, 12 for non-persistent cases. ADHD affects relationships. So it impacts ability to actively listen. Working memory means they forget what was said or forget that they would do something, forget birthdays or dates. ADHD is an intention disorder where you may intend to do something and not do it, or vice versa, where you intend not to do something, but there's that impulsivity and you do it anyway. It is not a knowledge problem, it is a doing problem. So it's helpful to write things down, it's helpful to set reminders, and with couples, psychoeducation and empathy will go a long way in helping that relationship. So ADHD can make it very hard to stay focused. It can make it difficult switching from one task to another. That's one of the features of it. So oftentimes that causes difficulty, or some people even panic. Memory issues are part of it. I talked about the 80% more dopamine receptors. It's something that you're born with. And it's not something that, like I said earlier, it's not something that has an onset. Now, with the 80% more dopamine receptors, this is likely why methylphenidate and amphetamines are helpful. They're not only reuptake inhibitors, but they are agonists. They create more dopamine. So with our current understanding, this is why, Ritalin and Adderall, those medications are helpful. So the treatment of ADHD, there's medication that is the most helpful. There's psychotherapy that is more changing environment and adapting to someone having ADHD. And then something many of you may not know about is neurofeedback. And that is learning to have a new arousal state using operant conditioning to kind of change brainwave patterns of ADHD. That one is not evidence-based, but it's considered efficacious and specific. So the next step would just be to prove that the placebo is not why there's change occurring. So with medications, stimulant medication and atomoxetine are the most effective. They improve 70 to 90% of clinical cases. They're convenient. They produce, yeah, they're very convenient. They're less expensive than psychosocial therapies over a long span of time. And they can be used years into adulthood. One of the most important things is, in my perspective, is that it is a neuroprotectant. So the ADHD brain will morph and change over time. The anterior cingulate will be affected, thinning of the cortex. Basal ganglia will be affected. The cerebellum will be affected. All of these parts of the brain will, and the ADHD brain will kind of morph. That is not the case when they look at people who have ADHD and grew up taking amphetamine or methylphenidate. So it prevented that change from occurring. So it has some really good long-term benefits. So the US approved ADHD medications, there's methylphenidate, amphetamine. These have been around for nearly 100 years with amphetamine. It has a lot of research behind it. Atomoxetine, that is more working with norepinephrine. And then there's even things like guanfacine that are used, but work in a different way. So the response rate for methylphenidate and amphetamine, 75%, trying all stimulants, 90% success rate. That's really good. There's even different delivery systems. So for people who, struggle with swallowing pills or need a different way to have it be administered, there's extended release, there's pumps, pellets, patches, liquid. There's a lot of ways to get this medication. Some of the benefits, there's better emotional control, there's increased concentration, decreased impulsivity, increased work productivity and accuracy, a decreased days absent from school, decreased aggression, decreased antisocial activities, which is higher with people who have ADHD, decreased suicidality, and decreased substance use. A lot of times providers are nervous about giving someone with an impulse control problem and giving them an amphetamine. That seems counterintuitive, right? But actually, when taken appropriately, like just when taken, it decreases drug abuse by around 60%, because once they're taking it, there is better impulse control. So there's a less of a need to self-medicate when you have it medicated and treated appropriately. Other benefits: improved self-esteem, better working memory, improved compliance, better awareness, peer acceptance. This ADHD has a huge social impact. Most of the kids by grade 2 are rejected by their peers because they are lagging behind in the social aspect. And typically they lag behind socially and academically for 2 to 3 years below their level. But medication can help that. So there's a lot here. There's a lot of good things that come from it. There are some side effects. It doesn't help everyone. There's some, often people will, to the stimulants, will have irritability. There can be difficulty gaining weight. There's some things that can come with it. When parents know about the side effects, it's good because they can take that and weigh it out. And if the side effects are too strong, they can adjust the dosage so that it's more appropriate. You want to find that sweet spot where it's helping and it's not causing issues. Some other side effects: increase in heart rate, increase in blood pressure. Those are some of the things that are common. I want to talk about the myths, and I apologize if I'm not getting to questions. I have a lot of slides. A myth is it's addictive when used as prescribed, and it's not. Like I said, it actually, when you take it as prescribed, it gives you better impulse control, and it reduces drug abuse by 60%. A myth is it creates aggressive behavior. No, it actually decreases that. Better impulse control, better emotional control. When you have something that is treating your emotion regulation disorder, you're going to feel better. You're going to be more in the moment. You're going to have better decision making. ADHD is a frontal lobe issue, and if you treat that with medication, it helps a lot of things. There's a myth that it increases risk of seizure. No, at very, very high doses, yes. Now, it does increase like beta wave activity. If someone has beta spindles in their EEG, I could see why someone would think that, but no, it actually doesn't. And in those cases, when someone takes it and they feel irritable because of that, guanfacine can be used. There's a myth that it causes Tourette's. No, it decreases those symptoms. There's a myth that ADHD kids are being overdiagnosed. No, they're being underdiagnosed. Underdiagnosed and also underprescribed. That goes to my next question. It's being overprescribed. No. So 4.3% of kids are on medication when the prevalence is 7.8. So there's a good chunk that are not getting the help they need. There's long-lasting effects from not taking medication that can, like just the life expectancy. The life expectancy without ADHD treatment is less. A risk of car accident so much greater. There's a myth that there's greater risk of later substance abuse. No, 15 studies found no such result. There's a myth that it doesn't improve academic achievement. Okay, maybe at very, very high doses it doesn't. but we have evidence to the contrary that it does. Yeah, improves productivity, classroom conduct, rule following, grades. Okay. Atomoxetine, same thing, reduces ADHD, ODD, aggression, improves self-esteem, faster time to sleep onset, improves executive functioning, less insomnia. There's a lot of benefits, whether it's stimulants or even a non-stimulant like atomoxetine. So if you have people who are resistant to taking a stimulant, atomoxetine is a good option. And it affects 70% of the same areas of the brain as ADHD, and it is thought also to be a neuroprotectant, but just thought. They haven't really actually seen that. I'm going to kind of skip ahead just because of time. So these slides, if you're interested, they can be made available to you. But I want to talk about the therapeutic treatments for ADHD. So there's behavior modification, CBT, and mindfulness. Behavior modification, so positive reinforcement, so rewards for staying on task, a token economy. There's visual cues and reminders, because time management is such a difficult thing for people with ADHD. So that can be helpful. Breaking things into tasks and steps can be incredibly helpful. So something that's overwhelming is now doable. Providing structure and routine is incredibly helpful. So was one story I saw where this kid would wake up, he'd go into the other room, he'd play video games, the parents would yell at him, and he would go downstairs and have a hard time, and he wouldn't eat. And then every morning was a nightmare. So these parents closed all the doors right before he woke up, put his clothes the night before right next to his bed. So he'd wake up, oh, there's these clothes. Put on the clothes, walk out the door. In the hallway, everything's closed. He's not stealing his attention. Walk downstairs. Oh, right there is breakfast on the table. Great. So he eats breakfast. Oh, right next to breakfast is his backpack. He picks up his backpack and leaves. Changing the environment helps. It helps a lot. So that's one of the things that can be helpful for families, whether it's couples or kids. Cognitive behavioral therapy, psychoeducation. Again, for parents, for the individual as an adult, learning what is outside of one's control, and then that means you can adapt to it. If I don't have to try to remember, if I can just write it down, perfect. Skill building, time management, organization, environmental modifications like the story I just gave, having family and parental environments can be very helpful. Mindfulness, this one I think is fascinating, because not only does it help brain and change the blood flow to the brain, but how it's helpful is interesting. So mindfulness, you're paying attention. So let's say you're noticing your breath, notice things spot just beneath your nose and above your lip. And then because you have ADHD, you get distracted. But then you notice that you got distracted. Well, now that you noticed you got distraction, you can redirect and come back to that spot. So when you can't prevent distraction, because distractibility is inevitable, you can practice noticing when you get distracted. And then you can practice redirecting back to where you were. So people with ADHD oftentimes will start meditating, and maybe they get distracted 5 times, about a minute each out of 20 minutes. And then later on, they get distracted 7 or 10 times, but then it's only just a few seconds each. So the distraction is still happening, but they're able to come back, and the total time they're distracted is less. It's by practicing noticing when you get distracted so that you can bring yourself back. It's not preventing distractibility, but it's increasing those skills to notice and come back. So these are some of the things that can help therapy-wise. So we have the treatment from medication, we have the treatment from therapy, but then there's also neurofeedback. This one is not evidence-based, but it is efficacious and specific. So this is operant conditioning to change arousal states observed in EEG. Around 80% of people with ADHD have significantly high theta wave in the frontal lobe, like statistically 2 or more standard deviations above the norm. Theta wave is associated with distractibility. In 2013, neurofeedback became efficacious and specific for kids with ADHD. In 2016, it became efficacious and specific for adults with ADHD. So what you would need to know about neurofeedback if you're referring someone is it can reduce symptoms. The ADHD does not go away. It doesn't necessarily help everybody. That's why QEEG is recommended, and that's the best practice to look at the brain first before you start making any changes to it. But it's also thought to be long-lasting. They've done studies where they look at the changes that happen a year later, and the changes did not revert to where they were. So this can help not just with the impulsivity, but it can help significantly with the distractibility. A QEEG is just an EEG with a lot of statistics. It's a way to look at the brain and see what is outside of the norm. So if you're referring someone to do neurofeedback, strongly recommend you have them go to a place that does a QEEG first, so that the protocols are tailored to that individual and using research. So the frequency bands, just a quick overview for some of you that may not know. The delta band, it's like 1 to 3, 1 to 4 waves per second. That has to do with sleepiness. Theta waves, just above that, like 4 to 7, 4 to 8, has to do with distractibility, daydreaming, creativity. Alpha waves, 8 to 12, and then beta is there on up to about around 30, 35. This is an example of someone that did a neurofeedback training. So at the beginning of their training, their delta wave was high, their theta wave was high, and their beta wave was low. Over the course of about 20 minutes, delta wave came down, theta wave came down, and beta wave came up. This is basically they watch a screen and it gets bright when the theta wave goes down. And so the brain, they want to watch their show, they want to watch their screen. And so it starts changing, and it's a subconscious thing. It's not something they're actively like trying to change. It's happening naturally. But yeah, it takes a few sessions to make this permanent, between 40 to 60, depending on the research that you look at. This is a normal EEG. Compare that to an EEG of someone who has ADHD. That's why we can do this. That's why this works, is because we can observe it. And if we can observe it, we can then use operant conditioning for it. This is a before and after of someone that had ADHD. They had that excessive theta wave in the frontal lobe. That is the biomarker, an FDA cleared biomarker. But this is not a diagnostic tool. It's even mentioned in the DSM that it's not a diagnostic tool. I believe you would need like 95% accuracy. This is 80. So it's just a biomarker. And you can see the before and the after. Now, for this person, they would still have some of those symptoms, just the severity of those symptoms would not be as intense. So if someone has a goal to, if they think about picture perfect and they're a good candidate for neurofeedback, they could maybe get 70% towards that, but they're not going to get 100. 70% is when they're a good candidate. And sometimes people are not. Now, as far as what is practical and what is helpful for your patients, going back to the idea of 80% more dopamine receptors. So if that dopamine is being vacuumed up, if I have a task I need to do, but I'm so bored and the wall is more interesting, if I flood my brain with dopamine, if I grab a snack, if I listen to music, if I play a couple quick chess games on my phone, I got dopamine from 3 different places, and now I can coast off of that dopamine and do the non-preferred task. So a dopamine dump will kind of get some momentum that your patients will be able to coast off of for a little bit. Time management is kind of going back to some of the CBT stuff. A lot of people don't know how to accurately use planners. People with ADHD, when you use planners, you need to have them schedule their meals. You need to have them schedule things that they need for their uh, for the, I guess sanity, really. Like, you don't want to go without meals. You could have them schedule free time, because if someone schedules all of their to-do list, they're just going to burn out. So learning to schedule, or practicing scheduling, okay, this is when I'm going to eat, here's when I'm going to have free time, and here's my to-do list, and now let's plug it in that, where the holes are. They're going to have some sort of normalcy where they're not going to feel overwhelmed. So those are a couple practical tips. I know I kind of rushed through it. I had a lot of slides to get to, but I want to open it to questions.
Yeah, this is great. Let me scroll up here in the chat and I'll see if we can answer some of these questions. Also, just want to take advantage of this moment. I'm going to put the evaluation in the chat one more time. If you want CE credit for this course, or if you just want the slides, I'm going to try to go through the chat log. It's recorded after this class, so I'm going to try to go through and get everyone's slides that wants them. But if you want a foolproof way to get those slides, go ahead and fill out this evaluation that I just dropped in the chat. You're going to need to use the class code that I also gave you. That verifies your attendance, your virtual attendance at this class. And then, of course, like I mentioned earlier, we're going to upload the course to our YouTube channel. So if you want to go back, I know there were a couple of people that said, hey, I want to go back to the previous slide. Don't worry about that. You'll get the slides, and I'm going to upload the class. But let's look at some of these questions that were asked earlier. Let's see. I know we had, I think here's where we're at. So Lisa had asked earlier, is there something in common with the people who get the executive function to come on with the parietal? What is different for them?
That's a good question. So yeah, I'm curious about that. And I would guess that there would be. But that's something that I imagine there's research of, but I have not, I'm not familiar with it. So I would just encourage you to look it up and let me know what you find out.
And here's another question. Can ADHD get worse over time?
Sure. I mean, there's a lot of things that can impact it. Stress. Like the example that I was giving earlier, like with kids, it not being as noticeable, but when they're adults and now they're having to do a lot more things than they did before, they're having to take care of their own planning, their own time management. Whereas before that wasn't, that wasn't a problem. They had someone to manage their time. So it can be worse going from one job to another. There's differences there. It can be worse on some days. Like if you get not as much sleep, that's really going to impact your executive functioning. So there's a lot of things that can impact your executive functioning that can make your executive functioning worse. Um, COVID, head injury, you didn't get sleep that night, other diagnoses, sleep apnea. Um, but as far as like research of it getting worse for a group of people over time, I'm unfamiliar with any research like that, but there is a lot of factors that can make executive functioning worse.
Okay, and Brooke had asked earlier, remind me what the frontal lobe and parietal lobe's functions are.
So don't want to necessarily oversimplify it, but the frontal lobe has to do, so that's the part that it was not as active. And it's also, side note, similarity here with people who can lucid dream, the frontal lobe isn't as active, but, or with people who don't lucid dream, but people who do, the frontal lobe becomes active. It's kind of interesting. So the frontal lobe has to do with inhibition, decision making. It also has to, I mean, there's multiple parts of the brain that have to do with like emotions, but also the frontal lobe has to do with emotions and what we do with those emotions. So when there's a problem with the frontal lobe, there's a problem with decision making. There's a problem with being able to regulate our emotions. So if we have an impulse or a desire to do something, the frontal lobe can say, no, I shouldn't do that. But if we have that impulse and the frontal lobe isn't working, then we could say the thing that's maybe funny or say the thing that's inappropriate. So when the frontal lobe is working, it's kind of helping us control our emotions and helping us control our behaviors.
Let's see some of the other questions that were asked earlier. Oh, here's a good one. In what ways can ADHD be differentiated from autism? This is someone asking, I'm aware of many similarities between the two.
Yeah, there's autistic people are more likely, much more likely to have ADHD. Also, people with ADHD, I think 30% have sensory processing problems. So there's structural differences in the brain. So the autistic brain favors shorter pyramid-like neurons. So say there's a lot of excess noise in the brain that can be observed in the EEG, but also a lot more resources are being used. Where ADHD is not, it doesn't have that quality. ADHD is more the more of a dopamine and a reuptake problem. So biologically, they're different. Does that answer your question?
I think that probably does. Rebecca had also asked earlier if you happen to have a handout geared towards parents or teachers about some of the topics we discussed today. I guess many parents are hesitant to try medication, and some teachers don't fully understand the accommodations they need to make for students struggling with ADHD.
You know, I don't have, I mean, I do have some handouts, but they're very elementary. I would refer instead to Russell Barkley's website. There's a lot of resources for parents, for clinicians, for teachers. So I would say if you look up Russell Barkley, ADHD, you find his website, there's going to be a lot of resources there.
Great. Here, it looks like some people are already asking for a part 2 of this class. I know it was very popular. We had a lot of information to cover today. We can discuss that. We can discuss that offline. Here's another question. Let's see. I ran across one here. Okay, here's one. Nate says, I was taught in grad school the best practice for treating ADHD in short-term medication paired with, let me see. He says, I was taught in grad school the best practice for treating ADHD in short-term medication paired with therapy. Is that true for the research you've seen?
Not necessarily short term. I mean, best practice is therapy and medication, yes. But it's not necessarily short term. With ADHD, typically that's something that is often going to require medication for the rest of the person's life. if they still have it as an adult, and if it's still problematic as an adult, then likely they're going to need that for the rest of their lives. Where if it's depression, something can come up, you have an antidepressant, you're in therapy, you work through it. That's something that can be temporary, but typically with ADHD, it's something that can be lifelong. That's not saying that it's always the case, because if you put in enough skills, you might not be able, you might, no, sorry, not able, but you might not need as much medication, or you might not need medication because you have all these skills in place. But typically, the benefits far outweigh taking medication than going off of it. There's a lot of more increased risks going off of it, just even going back to the life expectancy. So typically with ADHD, if it's still problematic as an adult, it's a good idea, likely, that them taking it the rest of their lives is going to be helpful. And there are non-medication treatments. There is neurofeedback. If they're a good candidate for that, that is thought to be lifelong. The changes from that are thought to be lifelong.
Great. And I know Tiffany asked, what's the best way for someone to go about with testing and diagnosis?
So testing is difficult. So psychological testing, it's going to be the most accurate, right? That's just no question. But it's not always accessible. So oftentimes testing might have a long wait list. So really it's deciding on whether you prioritize having something be very accurate, or you prioritize having, a treatment sooner. So if a child is diagnosed by a doctor without psychological testing, that may mean that they get accommodations, or can have accommodations at school. That may mean that they can get medication to treat them. That may mean that those symptoms are treated sooner than later. So it's really kind of a toss-up. So I'm not going to weigh in on what someone should do. There's benefits of really knowing what something is and what it's not. There's also benefits of getting treated sooner.
And Eva asked, in addition to distraction and inattention, how common is emotional outbursts as a common problem
All the
or
time.
symptom?
All the time. Yeah, because it's a regulation problem. It's emotion regulation and attention regulation. So it is incredibly common for emotional outbursts, because you're not able to stop yourself. So that's where the name kind of helps us not understand it as much. We look at it as attention deficit. It's a regulation deficit. So it's a regulation of attention. It's a regulation of emotions that is not as strong. So yes, all the time. It's almost expected.
And let's see, Amy asked, what's some good advice for couples where one has been diagnosed with ADHD?
So understanding it. So psychoeducation can be very helpful, and then setting realistic expectations. If my wife had an expectation that I would remember things, and if I had an expectation that I would remember things, and if I have ADHD, then this is almost outside of my reach. It's like I'm grasping at smoke, trying to grab a hold of something, but I cannot change my brain if it remembers something or not. But when you have an understanding, oh, this is what's going on, there's a working memory problem, the expectation can be you write everything down, you adjust to it. So the education can be very helpful. The understanding can be very helpful. listening to someone's experience, because one person's experience might be different than another. But something that I've seen is, let's say, they're in a casino, and they're walking through the casino, and partner's trying to talk to them, but there's all these lights, noises, sounds pulling their attention. They can't pay attention. They feel out of control because their attention is out of control. And so when you feel out of control, that's anxiety. So it goes from inattention to then anxiety. And then maybe they don't want to feel that way, so they leave that situation and they go outside, and now they're mad at themselves because they can't even listen to their wife while walking through a casino, and they should be able to. There's this domino effect of inattention, anxiety, and then shaming oneself. But when you understand this is outside of your control, it kind of stops that. So education can really help with stopping oneself from shaming themselves, being able to do something that's incredibly difficult, um, having more compassion, having more empathy, and setting more realistic expectations of what can be done, what to do instead when there's all this going on and this person's trying to listen, having a new behavior, saying, we'll need to talk in a few minutes. We'll need to talk when we get outside. I can't understand. Um, and having that expectation, oh, okay, my partner is, his attention's going everywhere. Okay, that's not going to work. I'll have to wait. So
Brooke had asked, what does the research say on ketamine and ADHD?
that's a good question. I'm not as familiar with the research on ketamine. Um, Anecdotally, I've heard things with it helping some people with like sensory processing problems. Um, but that's just anecdotal. So I really don't know.
And Jeanette had asked earlier, she says, I have a client that struggles to remember to do things and blames ADHD for it. They say reminder on their phone, putting things on the wall, etc., don't help. Do you have any tips on how to help clients remember things?
So one thing with ADHD is it's helpful to have things that are novel. Someone with ADHD might put a reminder on their phone, and then when it's no longer novel, it's no longer giving that dopamine. So what can be helpful is somewhat consistently changing the type of reminder. So if it's a reminder on the person's mirror, it's soon may be that that is in the background. It's no longer jumping out at them. But if you change the type of reminder every couple of weeks, okay, this week I'm writing things down. This week I am having things on my phone. It's constantly keeping something that's novel, which is going to produce more dopamine, which is going to grab their attention more.
Great. And kind of a follow-up to the question about testing, Tiffany's asking, what would someone look for in a provider offering testing? Like, is there a specific measure they should ask to be used?
I believe they've been using the TOVA for a long time. I don't think that's out of date. I don't, I couldn't really speak to that or give recommendations, but if it's a psychologist saying and they're fully licensed, they're doing psychological testing for ADHD, I would trust that expertise.
Great. I know we've lost a few people as the hour is now up. Was there anyone that wanted to just jump on quickly and ask Preston any questions? You can feel free to unmute or drop it in the chat, whatever you would like. I don't want to take away too much of his time, but was there anyone that's still on that would like to ask a question? Yeah, we are recording the Q&A. I'll make sure that that is included in the recording when I upload that to YouTube. So Yeah, we got a lot of great comments today. Thank you for your time, Preston. And just as a reminder, anyone who's still on, I will be uploading this recording to our YouTube channel. So go ahead and click on the link and subscribe. I should have that up by Friday if everything goes as planned. And again, I'm going to go through the chat log and make sure that everyone who requested these slides get those. But a really easy way to do that, if you want to make sure I don't overlook you, please go ahead and fill out the evaluation that I sent out. That tells me that you are interested in a CE certificate and the slides, or possibly one or both of those. So please do that. And if you run into any issues, I know that some of my friends at Intermountain, sometimes they can't always access the evaluation behind Intermountain's firewall. Feel free to email me. In fact, anyone who has issues accessing the evaluation, just shoot me an email. I'm happy to send it to a different email address of yours or help you, try to troubleshoot it as best we can. I want to give everyone who would like to get that CE certificate, I want to make sure you get that. And if you want the slides as well. So please, any questions that you have, go ahead and email me. Thanks again for your time, Preston. And thank you everyone for showing up today.
Thank you, everyone.